What if I told you that for millions of people out there who are suffering from severe, just totally debilitating pelvic pain, well, the pain isn't actually in their pelvis at all. It's actually in their brain.
I mean, yeah, it is a really radical shift in perspective. But for patients who have been suffering for years, I mean, it is often the exact key that finally unlocks effective treatment for them.
Right, because imagine for a second that you are waking up every single day with just severe agony in your lower body.
Hmm.
Like it hurts to sit at your desk, it hurts to use the bathroom, it hurts to be intimate.
Yeah, it completely takes over your life.
Exactly. So, you do exactly what you're supposed to do,
Mhm.
right? You go to a doctor, they run all the really expensive scans, they do the invasive laparoscopies, and then they sit you down in that cold little exam room, and they just say, well, we can't find anything physically wrong with you.
Which is devastating because
Yeah.
the expectation in modern medicine, it's usually highly visual and highly binary.
Visual meaning like they need to see it to believe it.
Yeah, right, exactly. We look for a broken bone on an X-ray or an inflamed organ on an MRI or a visible lesion during a surgery. And when we don't see those things, the medical system often just, well, it stalls out. It leaves the patient totally stranded.
Right. But the thing is, the pain is still there.
Yeah.
I mean, it hasn't just vanished because the MRI scan is clear. So what do you do when chronic pelvic pain persists despite a perfectly, healthy-looking pelvis?
That is the big question.
And that is exactly the mystery we are tackling today.
Huh?
We have a really fascinating stack of sources for this deep dive.
We do, yeah. Some really incredible literature.
Yeah, we are looking at clinical guidelines from NHS Scotland and the Cleveland Clinic, plus a truly groundbreaking paper from the Royal College of Obstetricians and Gynecologists, or RCOG, on targeting the nervous system.
And we also have some incredibly deep medical research on how conditions like vulvodynia and endometriosis actually, physically alter your brain chemistry.
Right. So our mission today is to completely upend our understanding of where pain actually lives.
We are going to explore how chronic pelvic pain can physically hijack the central nervous system.
And precisely how doctors are using the systematic addition of low-dose neuromodulators, specifically a medication called nortriptyline, to essentially hack the brain and turn the pain dial back down.
Yeah, it's basically a neurological reset.
Okay, let's unpack this. Because to understand the cure, we first have to totally change how we think about the location of the pain. Like we need to stop looking at the pelvis and start looking at the brain.
Right, but to get there, we first really need to define what we are actually talking about when we say chronic pelvic pain or CPP.
Right, because it's not just a bad cramp.
No, not at all. According to the RCOG and NHS sources, this isn't just a bad cramp during a menstrual cycle. CPP is defined as intermittent or constant pain in the lower abdomen or pelvis lasting for at least 6 months.
6 whole months.
At least, yeah. And crucially, it does not occur exclusively with menstruation or pregnancy.
And reading through the sources, I mean, it often overlaps with other just deeply uncomfortable issues.
Right. Oh, absolutely.
Like there's dysuria, which is painful urination, and dyschezia, which is severe pain during bowel movements, and dyspareunia, which is painful intercourse.
It is a pervasive, just all-encompassing condition that significantly reduces a person's quality of life. But here is the really paradigm-shifting insight we pulled from the RCO paper.
Lay it on us.
Let's say a patient does have a physical cause initially, like endometriosis. The surgeons go in, they perform an optimal, totally successful surgery, and they remove all the endometrial lesions.
So the physical tissue is completely healed.
Exactly. Yet the painful symptoms remain, and they are often entirely disproportionate to any remaining disease.
Wow.
Why? Because the central nervous system itself has begun to generate and perpetuate the pain.
I like to think of it like a car alarm.
Oh, that's a good way to look at it.
Yeah, like someone breaks into your car. That's the initial injury or disease, right? Like the endometriosis lesions. The alarm starts blaring to alert you that something is wrong.
Right, it's doing its job.
Exactly. But long after the burglar is gone, long after the car is locked up, repaired, and totally safe, the alarm is just permanently stuck blaring.
Yeah, the switch is broken.
So if the pain isn't in the pelvis anymore, what exactly is happening in the nervous system to keep that alarm ringing?
Well, what you're describing points directly to a phenomenon called central sensitization, which is heavily detailed in the research we have on vulvodynia and endometriosis.
Central sensitization. Okay.
Yeah. Let's look at the evolutionary purpose of pain for a moment. If you sprain your ankle, Your body wants that area to be incredibly sensitive so you won't walk on it.
Right, it's trying to protect you.
Exactly. Central sensitization is essentially what happens when your body overprotects you and then completely forgets how to reset the system back to normal.
So the body's protection mechanism just goes into overdrive and gets stuck there.
Exactly that. It starts with an initial noxious stimulus, say, actual tissue damage in the pelvic organs.
Okay, the burglar breaking in.
Right. Specialized nerve endings called nociceptors send impulses up to your central nervous system. And these signals, they travel via two main types of nerve fibers, A delta fibers and C fibers.
Wait, hold on. Let's break down those fibers for a second because the sources mention that A delta fibers are myelinated and C fibers are unmyelinated.
Yeah, that's the medical terminology.
Are we talking about like microscopic wires here? What does myelin actually do?
That's actually a great analogy. Think of myelin as the rubber insulation on a copper electrical wire.
Okay, I can picture that.
So A delta fibers are myelinated, meaning they have this thick insulation that allows the pain signal to travel at lightning speed. They deliver that sharp, immediate ouch when you cut your finger.
Right, the fast pain.
Exactly. C fibers, on the other hand, lack that insulation, so they transmit the slow, throbbing, aching pain that comes later.
So in this chronic pelvic state, you have this relentless barrage of fast and slow pain signals just hammering the spinal cord and the brain.
Right. It never stops. And this continuous hammering causes something called neurogenic inflammation.
Meaning the nerves themselves get inflamed.
Yes, the nerves themselves get inflamed and start spitting out chemicals. The sources specifically highlight neuropeptides like substance P and calcitonin gene-related peptide, or CGRP.
Okay, substance P sounds like a made-up sci-fi drug. What do these chemicals actually do?
I know it does sound sci-fi, but they act as aggressive messengers that essentially tell the nervous system, hey, we're under constant attack, ramp up the defenses.
Oh, wow.
And over time, this chemical flood induces a state of synaptic neuroplasticity.
Synaptic neuroplasticity. That means the brain is changing, right?
Yes. Your nervous system is incredibly adaptable, which is usually a good thing, but here, it literally rewires itself to become a highly efficient pain processing machine.
So the hardware actually changes.
The hardware and the software.
Huh.
The sensory processing in the brain is completely altered. You see an increased reactivity in specific receptors, namely NMDA and AMPA receptors, which sit at the synapses where nerve cells communicate.
So these receptors are just pulling in more pain.
Exactly. When these multiply and become hyperreactive, it leads to two devastating clinical realities. First, hyperalgesia, where things hurt much more than they normally should.
And the second.
Allodynia, where things that shouldn't hurt at all, like, say, just the light touch of clothing, suddenly cause severe pain.
That is just the pain becomes completely uncoupled from the original physical injury. It's wild.
It truly is. The brain's structure, function, and neurochemistry are profoundly altered. And on top of that, the descending pain inhibitory mechanisms become completely dysfunctional.
Let's translate that real quick. When you say descending pain inhibitory mechanisms, you mean the brain's natural ability to hit the brakes on pain?
Yes, that's a perfect way to phrase it. Normally, your brain receives a pain signal, registers it, and then sends a signal back down the spinal cord to say, okay, message received, you can stop hurting now.
It's like an off switch.
Exactly, it's an off switch. But in central sensitization, the chemical flood we talked about earlier basically jams that off switch.
It just gets stuck in the on position.
Right. Which brings us to the treatment side of things.
Yeah, because if the brain's architecture is now actively amplifying normal signals into severe pain, taking a standard painkiller like ibuprofen or an NSAID is just useless.
Oh, completely useless.
It's like trying to fix a software glitch on your computer by, I don't know, replacing the physical monitor. You're treating the hardware in the pelvis, but the bug is deep in the central nervous system's code.
That is the exact perfect way to look at it, and it explains why the guidelines from the Cleveland Clinic and NHS Scotland are so emphatic about this.
Right, they really stress this point.
They do. For central sensitization, standard over-the-counter analgesics have virtually no evidence of efficacy. Instead, doctors have to turn to neuropathic agents.
Tools that can actually cross the blood-brain barrier and rewrite that glitchy code.
Exactly. And the sources mention a few of these. Gabapentin is one, usually starting at maybe 300 milligrams and titrating up.
But the heavy hitters, the frontline defense highlighted across the board, are the tricyclic antidepressants, right? The TCAs.
Yes, the TCAs. Amitriptyline is a common one. But the Cleveland Clinic and RCOG strongly highlight nortriptyline as a highly effective, acceptable initial alternative for treating systemic chronic neuropathic pain.
Okay, but wait. I have to push back here for a second, just, you know, channeling anyone who has been in this position.
Sure. Yeah, okay.
If I go to a doctor for severe physical debilitating pelvic pain, pain that hurts when I walk or sit, and they hand me a prescription for an antidepressant like nortriptyline, I'm going to feel incredibly insulted.
I completely understand why.
Right. I'm going to think they were telling me it's all in your head, or that I'm just depressed because I'm in pain, so they're just treating my mood. How is this not just treating depression and ignoring the physical pain?
You are hitting on a massive point of friction in medical care, and the RCOG paper actually explicitly acknowledges it.
Really? They mention that friction.
They do. They note that women frequently report feeling that their doctors thought their pain was purely psychological. It is a massive failure of medical communication.
Yeah, I mean, it completely breaks down trust.
Exactly. The crucial distinction we have to make here is that the analgesic or pain-relieving activity of a drug like nortriptyline is completely independent of its antidepressant activity.
Completely independent, meaning it is doing a totally different job in the body.
Yes. And we know this for a fact because of the dosage. When nortriptyline is used to treat clinical depression, a psychiatrist will prescribe a much higher dose, often upwards of 75 to 150 milligrams a day.
Okay, so that's the depression dose.
Right. But when a pain specialist prescribes it for chronic pelvic pain and central sensitization, they use a microdose.
I can just imagine the confusion at the pharmacy, honestly. The pharmacist sees a prescription for 10 milligrams of an antidepressant and just thinks it's a typo.
It happens. It really does. The NHS Scotland guidelines suggest starting an alternative tricyclic like nortriptyline at just 10 milligrams, usually taken at night, and then slowly increasing it every 2 weeks to a maximum of about 50 milligrams.
Okay, so to be abundantly clear for everyone listening, at these tiny doses, it's not being used to alter your mood at all.
Not at all. At a 10 milligram to 50 milligram dose, the drug is not functioning as a mood elevator. It is acting systemically as a neuromodulator.
It's a physical tool.
Exactly. It is a highly specific chemical tool designed to target the nerves and the brain, not your emotional state.
Okay, well, here's where it gets really interesting. Because if we know it's acting as a neuromodulator, we have to ask how. Like, what is this tiny 10 milligram pill of nortriptyline actually doing on a microscopic level inside this hypersensitized brain?
To understand the pharmacology of relief, we really have to look back at the neurobiology from the ARCOG and vulvodynia papers. Remember those NMDA and AMPA receptors we talked about?
Yeah, the one sitting on the synapses.
Right. In a state of central sensitization, they are hyperreactive. They are wide open, just grabbing every single physical sensation from the pelvis and magnifying it into blinding pain.
Right. It's like having a wildly paranoid roommate who thinks every single knock at the front door is a SWAT team, so they just start screaming. The volume dial is stuck at 11.
I love that analogy. It's exactly like that. What nortriptyline does is alter the activity within the pain inhibitory systems.
So it calms the roommate down.
Yeah. It modulates key neurotransmitters, specifically serotonin, noradrenaline, dopamine, and acetylcholine. But most crucially for this type of pain, it acts as an NMDA antagonist.
Okay, let me make sure I'm visualizing this correctly. If central sensitization is the brain turning the volume dial of pain up to 11 by aggressively multiplying and opening those paranoid NMDA receptors,
right,
taking systematic low-dose nortriptyline is basically sneaking into the control room and unplugging the amplifier entirely.
You've got it. Being an antagonist means the drug physically binds to those NMDA receptors and blocks them from transmitting the exaggerated pain signals.
So it stops the paranoid roommate from screaming.
Exactly. But it doesn't just block the bad signals, it also actively works to repair the broken system.
Wait, how does it fix the system? You mentioned it modulates neurotransmitters like noradrenaline and serotonin, right?
Right. In the spinal cord and the brain, noradrenaline and serotonin actually act as the body's natural brakes for pain.
Oh, interesting.
So by boosting the presence of these inhibitory neurotransmitters in the synapses, nortriptyline helps repair those dysfunctional descending pain inhibitory mechanisms we talked about earlier.
It's fixing the jammed off switch.
Exactly. It empowers specific control centers in the brainstem areas like the rostral, ventromedial medulla, and the periaqueductal gray.
Okay, those are some heavy medical terms.
Yeah, you don't need to remember those complex terms. Just think of them as the brain's internal pharmacy and dispatch centers.
The dispatch centers, I like that.
Nortriptyline gets those centers back online so they can start sending suppression signals down the spine again. It is literally teaching the brain how to block out false pain signals and function normally.
And the sources mention it does even more than that, right? Like,
Yeah.
the RCOG paper noted some other effects.
It does. The paper notes that nortriptyline potentially has direct opioidergic and anti-inflammatory effects on the central nervous system itself.
Opioidergic, meaning it acts like an opioid, like morphine.
Not quite like taking a systemic opioid pill, no. But it stimulates the body's endogenous opioid system.
Meaning the painkillers our bodies make naturally.
Exactly. It prompts the brain to utilize its own natural internal painkillers more effectively right at the site of the nerve synapses. And the anti-inflammatory effects help cool down that neurogenic inflammation that started this whole mess.
Okay, so what does this all mean for you, the listener, if you or someone you love is navigating this? What is the clinical reality of starting this treatment?
And it's a really important question.
Because from what you were describing, cooling down inflammation, rewiring synapses, blocking receptors, this isn't like taking an aspirin where your headache is magically gone in 20 minutes.
Not even close. It is a process, and it requires significant patience. The vulvodynia study we reviewed makes a critical point. This systematic alteration takes time.
How much time are we talking?
Patients who have developed central sensitization take significantly longer to respond to treatment, often well over 2 months of daily medication before they feel a change.
Which logically makes perfect sense, honestly. I mean, the nervous system didn't rewire itself into a state of chronic pain overnight.
Right. It took months or years.
Exactly. It took months or years of constant signaling from the pelvis to build those extra receptors. So a low-dose neuromodulator isn't going to unwire that architecture overnight either.
It is a slow structural and chemical reset. And because it is so complex, the clinical guidelines from NHS Scotland emphasize that a pill alone is rarely enough.
So what else do they do?
Multidisciplinary care is essential. The research shows that chronic central pain actually alters the HPA axis.
The HPA axis, that's the hypothalamic pituitary adrenal axis, right? The system that controls how your body responds to stress.
Correct. When you are in constant unyielding pain, your brain thinks you are in mortal danger.
It literally thinks a tiger is chasing you 24/7.
Precisely. So it floods your body with stress hormones like cortisol. Living in that state of constant chemical alarm leads to secondary anxiety and depression purely as a physiological consequence of the chronic pain state.
Wow, okay.
Therefore, screening for and treating this secondary distress is standard, necessary practice.
Because it's not because the pain is in your head, it's because the pain is destroying your neurochemistry.
Right. NHS Lothian in Scotland, for example, they heavily integrate a computerized cognitive behavioral therapy program for people with chronic pain alongside the use of neuromodulators like nortriptyline.
So the CBT helps manage the psychological fallout of the cortisol flood, while the nortriptyline repairs the physical synapses.
Exactly. It's treating the whole system, not just the symptom.
Looking at all these sources, the thing that stands out most to me is how deeply validating this science is.
It really is.
For decades, patients, mostly women, given we're talking about pelvic pain, have been told that because their pelvic scans are perfectly clear, there's nothing wrong with them.
Just incredibly dismissive.
But this research proves that the pain is physically, measurably real. It hasn't disappeared, it just migrated. It moved from the tissue of the pelvis into the neurochemistry of the brain.
That is the ultimate takeaway here. The pain is not imagined. It is generated by a central nervous system that has been physically injured and structurally changed by sustained distress.
Right.
Recognizing that central sensitization is the true culprit is, well, it's the absolute first step toward actual relief.
So to summarize our journey today, we started with a frustrating, unyielding pain in the pelvis with no obvious physical cause on a scan.
Yes.
We discovered that the central nervous system was actually generating and perpetuating that pain through a process of synaptic neuroplasticity called central sensitization, basically building more receptors to amplify the signals.
Right, the volume knob at 11.
And finally, we learned how a very specific, low-dose neuromodulator, like nortriptyline, acts as a neurohacker. It sneaks into the brain, acts as an antagonist to block those hyperreactive NMDA receptors, and boosts natural brakes like serotonin to repair the brain's normal pain inhibitory pathways.
It really is a remarkable application of neuropharmacology, turning a medication originally designed for one thing into a highly precise tool for chronic pain management.
It really is. But before we wrap up, I want to leave you with a final, maybe slightly provocative thought to mull over.
Oh, let's hear it.
We learned from the RCO taper that chronic pain causes long-lasting structural changes to the brain, right? Like the brain learns how to be in pain.
Right.
We also learned that neuromodulators like nortriptyline can physically block the brain from amplifying that pain.
Yes, as an antagonist.
So if we know the brain learns this behavior and we have the tools to block that specific learning process, could the early temporary use of these low-dose medications immediately following a severe pelvic trauma or surgery one day be used not just to treat chronic pain, but to act like a vaccine?
Oh, wow.
Like, could we actually prevent the central nervous system from ever learning how to be in chronic pain in the first place?
Now, that is a truly fascinating frontier. I mean, if we can intervene before the neuroplasticity sets in, the preventative implications are staggering.
Something to really think about. Thank you for joining us on this deep dive. Keep questioning the world around you. Keep looking for the why behind the what, and we will catch you next time.